Hello, and thank you for your interest in this B-Stroke Smart program. I'm Sherry Farney from the Marketing Department at McLaren Flint. Following Dr. Majjhoo's presentation, he will take your questions. Please feel free to type those in the Q&A bubble located at the bottom of your screen at any time, and we will get to them, as many of them as we can in the next hour. It is my pleasure to introduce Dr. Aniel Majjhoo, an interventional neurologist. He is board certified in neurology, vascular neurology, and neurocritical care. He completed his neurology residency and a fellowship in vascular neurology at Detroit Medical Center in Detroit. He completed an additional fellowship in neuroendovascular intervention at St. Joseph Mercy Oakland in Pontiac. Dr. Majjhoo received his medical degree from Wayne State University in Detroit. He is chairman of the Neuroscience Research Council for McLaren Health Care and also medical director of neurosciences at McLaren Health System, which includes the McLaren Stroke Network. Please welcome Dr. Majjhoo.
Thank you, Sherry. So today I will be speaking, since it's May is Stroke Awareness Month, I'll be talking about things we can do to be more stroke smart. To be honest with you, my presentation will include a lot of the treatment options for stroke, but I will talk about the signs and symptoms of stroke and what we can do to prevent it from happening in the first place. So in our country, stroke is the 5th leading cause of death, and it's the #1 cause of morbidity. So that equates to about 800,000 strokes per year, and then about 20% of those dying per year, so about 128,000. Every 40 seconds, someone's having a stroke in the United States. Every 4 minutes, someone's dying from a stroke. So by the end of this presentation, after 30 minutes, about 45 people have died in our country. So that's just to give you some perspective. Large vessel occlusions are one of the big pipes being occluded in the brain, and we'll talk a little bit more about that, and that's about 40% of the time. And treatment options are different depending on what kind of stroke you're having, so it's very important for us to discuss that today. So when you're in elementary school, maybe middle school, they taught you about left brain and right brain, and they talk about left is more concrete thinking and the right brain is, you know, the more artistic side of your system. As a neurologist, you know, we see things a little bit different. You know, these things are true. However, we look at more concrete things. So most right-handed people have a left dominant brain. And what that means is your language, your ability to communicate, the ability to understand language comes from it. Your ability to move the right side of the body, so the opposite side of the body comes from that. And your right brain controls your left side of the body in most patients, and your ability to perceive that side as well. No matter where it is in the brain, where you can have damage to the brain, obviously can lead to significant deficits. So it's very important for us to discuss what we can do to prevent that. So as a vascular neurologist, I like to make the analogy that we're like the plumbers of the neurologist. So we're looking at the plumbing system, the arteries and the veins of the brain itself. Whereas an epileptologist or a seizure doctor would be more the electrician of the brain. So the two types of stroke, the majority of stroke is ischemic. So 87% are where one of the major pipes has some blockage in it. So that's what causes an ischemic, or not enough blood flow to the brain, which causes this lack of oxygen and nutrients getting to that part of the brain, and eventually that part of the brain dying. And that's where it leads to the deficits. A hemorrhagic stroke is when one of these pipes bursts and you have outflow of blood into the brain itself, and the after effects of the blood on the brain. You know, there's swelling, a multitude of bad effects of this inflammatory reaction when you get blood on the brain. So we definitely don't want that to happen either. So let's start off by talking about the ruptured blood vessels, or the hemorrhagic strokes. Now, on a CAT scan, this is what it appears like. This bright substance is blood, this is the left side of the brain. CAT scans are really the opposite. So this is the left side, this is the right side. The left side is where you see more of this bright tissue, substance. And that's the blood on the brain, and the black stuff around it is swelling. So the bleeding that can happen in the brain, there's different treatment options. A lot of it is medical, and as a neurointensivist, we take care of those type of patients in the neuro ICU. It might be blood pressure control or certain medications. But, the one that I'm going to talk about more so is aneurysms. And again, ischemic stroke is when you have blockage in the brain, and on a CAT scan, you would see this swelling in the brain and this dead brain tissue, and it starts to push on other structures. So that's a very bad situation as well. So before I tell you about that, I want to tell you a little bit about our program at McLaren. So the McLaren Stroke Network was started in August of 2015. We have 2 level 1 stroke centers. And what do I mean by level 1? It's like a level 1 trauma center. So we have places where we do the surgical treatments for strokes and their aftercare in a neuro ICU. So that's at McLaren Flint and McLaren Macomb. We have level 2 stroke centers in Lansing, Lapeer, Port Huron, Oakland, and Bay and Northern, in Petoskey. And we have stroke ready hospitals and standalone ERs and other hospital systems that send us some of their complex cases as well. So back in 2015, we figured how we're going to cover, this is like half of Michigan, efficiently. So we had adapted telemedicine. So that with telemedicine, we were able to bridge the gap in rural communities, improve access to stroke care across Michigan, standardize stroke care across the McLaren Health system, and develop an algorithm to rapidly assess patients for stroke. And this gave us the capability to have 24/7, 365-day specialists on call to see patients anywhere throughout the McLaren Stroke Network. This led to obviously better outcomes and better quality of life for our stroke patients. And we accomplished this with having primary stroke call taken by interventional neurologists. What that means is the same physician that's going to perform your surgery is the same one that's seeing you in the emergency room, making a decision which medications you need or whether you're a candidate for that clot busting medication TPA or not, looking at the imaging as soon as possible, evaluating you, talking to you and your family to make informed decisions on surgery options, and making sure that you are treated in a timely fashion. And this is our group. You see myself in the middle. You see Dr. Naravetla, who is the director of our telemedicine group, and Dr. Reyes, who is the director of our cath lab, and myself, the director of neurosciences. We are all board certified in neurology, vascular neurology, and neurocritical care. And we are all 2-year trained in interventional neurology. What that means is we went to school for a long period of time. So we make those decisions, again, for TPA, is that clot busting medication, again, going back to the plumber analogy. So it's the liquid Drano. So you take the medicine through an IV, it goes up into your brain and opens up those blood vessels that are blocked. But there's time constraints for that drug where it's safe. It can only be given to patients within 3 hours of the onset of symptoms. And some in 4.5. It depends on the patient, their characteristics, and who is eligible and who is not. So these difficult decisions are made by our specialists on call 24/7, 365 days a week. I'm happy and proud to say that McLaren Flint, this is our 2nd year in a row, we're awarded with the highest level of quality care by the American Heart Association. This is the highest level award that a hospital can get for stroke care and for the surgical management, as well as the TPA medical management for stroke patients, giving that medicine, that TPA within 30 minutes, majority of the time of getting into the hospital. You think 30 minutes is a long time, but really those patients get in, you got to be evaluated. They have to have CAT scans, they have to have laboratories, they have to see their inclusion, exclusion criteria, make sure that they can have the medication, and then decisions about thrombectomy. And we do all that with those 3 physicians very efficiently every day. And we've gotten this highest level award, which ranks us as one of the top programs in the country at this time. So when I talk about stroke, I'm going to talk about hemorrhagic stroke now, and I'm going to talk about those, those bursted pipes, and I'm going to focus on aneurysms. So it's a weakening of the blood vessel wall that causes an out-pocketing of a blood vessel, and if it gets large enough with like smoking cigarettes or high blood pressure, it can rupture. And their treatment options involves placing a clip at the neck of the aneurysm so it cannot rupture, or filling it up with platinum coils. So this is an aneurysm blowing up. Obviously, about half the people die when this condition happens before entering the hospital. So we definitely want to prevent this. And neurosurgeon can do an open craniotomy and place a clip at the neck of the aneurysm to prevent blood flow to the aneurysm and excluding it from the vasculature so it cannot rupture. Or a neurointerventionalist like myself can make a minimally invasive small incision in the groin or the wrist, go through the arteries with these small catheters and pipette these little platinum coils into the aneurysm, excluding it from the vasculature. Sometimes they're a wide neck and we have to place stents at the base of the aneurysm and then go through the stent, and we use the stent as a scaffold, and we place coils in the aneurysm to exclude it from the vasculature, and the stent keeps the blood flow to the normal blood vessels. This is an example of a patient with a basilar artery aneurysm that was coiled, and you see the stents that are holding the coils in place. There's a newer device, a flow diverter technology, where they place a stent across the neck of the aneurysm. And this has got like more mesh so that it doesn't need the coils. And with this, you place this just a stent alone across the neck of an aneurysm, and it decreases the flow to the aneurysm over time. And as you can see here, like it's just trying to show how the blood flow is going through, and the stent is excluding the aneurysm, and over time, the aneurysm shrinks. This is an example of that, of a patient treated with that flow diverter device. So the patient had a large aneurysm, and the aneurysm itself has an aneurysm. But with the stent in place, after 6 months, the aneurysm's totally gone. This is the latest aneurysm device. It's called a web embolization device. It's like an intrasaccular device where you actually put this umbrella type device into the aneurysm so you won't require stents. And here's a patient with an anterior communicating artery aneurysm that we placed one of those devices into. And this is the first case we did in Michigan where, with a live deployment, you see the device going into a basilar tip aneurysm. Actually, that was an ACOM aneurysm, I'm sorry, but you get the idea. So that was, so now that we've talked about hemorrhagic stroke, let's talk a little bit about ischemic stroke. That's the majority of strokes, about 87% of strokes. So again, that's a blocked blood vessel, not allowing enough oxygen and nutrients to get to the brain, and resulting in end damage. So as promised, we're going to talk about risk factors of strokes. And there's things in life that are modifiable risk factors and then non-modifiable risk factors. The non-modifiable risk factors are things like our gender, our race, our family history, our genetics, our age, but the modifiable risk factors are things like high blood pressure, high cholesterol, diabetes. If you had a history of stroke, making sure that you figured out what was the cause of that stroke and making sure that you're on the correct medication so you don't have another one. Or you may need a surgery to prevent another stroke. We'll talk a little bit about that as well. Atrial fibrillation is this irregular heartbeat that you can have that can make you more prone to having strokes. The little clots are formed in the heart and shot off to the brain. So you have to be on certain blood thinners and certain rate control medications prescribed by a cardiologist or your neurologist to prevent those strokes from happening. Other modifiable risk factors are like a sedentary lifestyle, exercising appropriately, avoiding obesity, and of course, smoking cigarettes, we know is linked to a higher risk of stroke, both hemorrhagic and ischemic. So some are the signs and symptoms of strokes, whether it be a bleed or hemorrhagic ischemic stroke, are a sudden onset of neurologic symptoms, whether it be a sudden onset of weakness on one side of the body or the other, a sudden onset of facial droop, difficulty with speech, understanding it, or dysarthric or slurred speech, sudden onset of a confusion, sudden onset of visual defects where you can't see out of one side of your eye or the other, or like a curtain gets put over your eye, like it just blacks out vision, neglect of one side of your body or the other. Sudden onset of dizziness can be a stroke. Nystagmus is where your eyes are like dancing. Sudden onset of difficulty of swallowing, or your eyes get fixed to one way or the other. Sudden onset of double vision, decreased coordination. A sudden onset of a terrible headache can be a sign of a bleeding stroke, especially. And a sudden onset of numbness and tingling, paresthesias. So at McLaren, we use the mnemonic B.E.F.A.S.T. So the B stands for balance, so the sudden loss of balance. The E stands for eye, so if you have sudden trouble with seeing or double vision. Sudden, the F is for face, so you start to see a crooked smile. The A stands for arm, so one arm gets weak or the other. S is for speech, so slurred speech or drooling. And T is for a terrible headache. Time is of essence. So what should you do? You got to call 911. Do not wait. Do not drive. Do not take an aspirin, because you don't know if it's an ischemic or a hemorrhagic stroke. And aspirin is a blood thinner. So if you take an aspirin, you could actually be making things worse. For family members or people who are witnessing the event, you got to know when the patient was last normal, because that makes a difference in whether we can give certain treatments, that TPA medication or not. So that is very important. We got to know the medications they're on, because if they're already on a blood thinner, if they're on like what are called DOACs, like Eliquis, Xarelto, those type of medications, they may not be a candidate for TPA, because those medicines with TPA are not studied, and it may make it an increased risk of bleeding. So we don't want that to happen, because when you bleed in the brain, patients die. So we don't want that to happen. So we got to make sure we know their medicines that are on. Any type of medical history, whether they have atrial fibrillation or carotid disease, or hypercoagulable state where they have a clotting disorder. We need to know these things. And an emergency contact. I have an Apple phone, they have the health app. A lot of these things you can enter in there now, your allergies, your medication list, your prior medical history, so it's important for you to keep all those things into consideration. I'm going to go back to what we do in the lab. So this is what our view is. It's myself, Dr. Narabella, Jill, one of our techs. We're looking at a monitor here and treating that patient. Actually, that patient's the stent coiling I showed you, this is that case where we are treating an actual patient. And this is a view from a different angle. That's the X-ray machine that we examine the patient. The patient's lying there, and we have one way looking front and one on the side, seeing the patient. So vasculature when we put the catheters up. And I hope no one's squeamish, but I'm going to show you some videos as well of an actual thrombectomy. This is actually performing one of those ischemic stroke procedures. We're sticking a catheter through an artery in the leg, tracking that a large catheter up into the neck over a wire. See, this is the patient's spine. You see their heart beating. You see their spine. This is the view that we have when we're doing these procedures. See the other small little catheter going up? This is all clotted vessel. The patients are awake, by the way, while we're doing this. We give them medicines to make them comfortable, but we want to keep them awake, because that's when we see best outcomes. And you need a trained, specialized physician to perform these procedures who's done a lot of these, so they know what they're doing. So we stick the wire through the brain, blood vessels, and we bring the catheter up, and you see the occlusion. This is a right middle cerebral artery occlusion. So this patient most likely could not move their left side of their body, maybe neglecting that side. So then you stick a wire through the clot, and then you follow that with a microcatheter. And you see that little small catheter going through the clot, and that's usually uncomfortable for the patient. That's why you saw the head move a little bit. But again, if it beats putting the patients under general anesthesia and having worse outcomes. So that's why we do these things awake, and time is of essence as well. So we want to do it as quickly as possible. We might do a microcatheter injection to make sure we're replacing the stent retriever device in the right place. And here comes the stent retriever device. This one in particular is a solitaire. At every centimeter, there's every 10 millimeters, there's a marker that you see here. And this one's 40 millimeters in length, and it's going to be deployed right into the clot. So basically we line it up where the clot is, and then we unsheath and remove the microcatheter, and you see the stent spring open. Once we do that, the stent is integrating, opening up the blood vessel and integrating with that clot and holding it. So this procedure itself, we can do within minutes from getting the patient in the lab and getting to the point where we can actually revascularize the blood vessel. So we get the stent retriever open, and then we hook up to a vacuum, this larger bore catheter, and we open up the blood vessel. Here's another technology where we use just a vacuum device. So we have these large bore catheters, and we can bring them right up into a clot and turn on the vacuum and vacuum these clots out. You see the large bore coming up, and then you see the clots that are removed. That small clot can cause major deficits, death, or worse, being left in a nursing home for the rest of your life. This is a left hemispheric stroke. This is us working in the lab, and you can see once we pull the catheters out, they flush the catheters out, and the clots removed are very small, and we're working with very small blood vessels. So it's very delicate procedures. This is a patient I treated on Friday. She is 76 years old. She did not know she had atrial fibrillation. Her husband is semi-retired, but he's still working. He left the home at 10 o'clock, and when he got home at 6 p.m., he found her on the kitchen floor, face all bruised up, couldn't speak, couldn't move the right side of her body. Did the correct thing, called 911. They brought her to the ER, but the patient was not a TPA candidate because we didn't know when the last known well time was. But I took the patient to the lab. Within 9 minutes, we were up in the brain and removed the clot. Patient's completely improved and is at home and is totally intact today. And we started the patient on anticoagulation, so they will not have a stroke in the future. Through the McLaren Stroke Network, obviously, we like all the cutting edge tools, and we like all the cutting edge medication and technology. And so we participate in research quite a bit. We're involved currently and in the past in many trials. A lot of them are NIH sponsored, and we continue to, we're very interested in research and taking it to the next level, stroke care to the next level. But this is not possible without our team. So we have 24/7 advanced practice provider coverage. What that means is we have nurse practitioners, advanced practice providers, physician assistants that are in the hospital all day, while the physicians are not. And again, we're covering all the hospitals by telemedicine, and we're there to do the surgeries. But at night and during the day as well, we have our advanced practice providers at the bedside all the time, and it takes a team effort to take care of these patients, not only in the lab, in the emergency room, in the lab, in the neuro ICU afterwards, and then in rehab. A lot of these patients require inpatient rehab and to get back to their usual daily activities. This is our neuroscience coordinator, Ashley and Madi, our advanced practice providers, Lucian and Holly and Jennifer and Marty, and I don't know if any of them are listening, but I'm trying to give them a shout out right now. Dan, Jessica, Christina, Dr. Nervella, Dr. Reyes, Dr. Norris. Thank you, y'all. You guys do a wonderful job. And I want you guys to be all assured at McLaren, we are taking the proper precautions with COVID-19. With COVID-19, we have seen an increased amount of bleeding in the brain, and we also have seen ischemic strokes. And there was initially the hesitancy for patients to actually go to the emergency department. We're glad that that's changed now. However, we are taking all the precautions to make sure that we are keeping your loved ones safe, as well as keeping ourselves safe and our families safe. And it's very important to do so. But also, I can't do a talk during a pandemic without throwing this in. Guys, this is the McLaren website, mclaren.org//COVID-19 vaccine. If you haven't done so already, please register for the vaccine today. All three of them are available, Johnson & Johnson, Pfizer, Moderna. You pick which one you want. Go to the website, pick the date you want to go there. They have drive-up clinics. Please, I encourage you to do it. I've had the vaccine for since January myself, second dose. Fine, you'll be fine too. Please get the vaccine. Let's beat this pandemic together. So I'm going to be finishing up soon, but again, I want you to stress the fact that 80% of strokes are preventable. It's all about risk factor modifications. So high blood pressure, high cholesterol, atrial fibrillation, all these things are treatable. If you have carotid disease, you may need a surgery. You might need an endarterectomy or a stent to prevent a stroke. Diabetes, hemoglobin A1C less than 7. Smoking cigarettes, please do not smoke. They cause a stroke, heart attack, cancer, you name it, smoking causes it. So please do not smoke cigarettes. If you have a previous history of transient ischemic attack, which is like a mini stroke or a stroke, you're at higher risk than the general population for a stroke. So let's make sure you're on the right medications so that doesn't happen. And if you have a family history of stroke, you might have a hypercoagulable disorder. You might need to be on some certain blood thinners. Let's look into that more. So make sure you're on a healthy diet, you exercise, you maintain a healthy weight, you improve your cholesterol with the diet and exercise, and you might need a medicine, a statin, to help with that as well. Take your prescribed medicines, stop smoking, monitor and control your blood pressure, control your diabetes and your blood sugars, and keep your regularly scheduled doctor visits, whether it be via telemedicine or in person. Please go see your doctor and make sure that you don't have a stroke in the first place. Thank you very much. And at this point in time, I'll be taking any questions. I apologize for the technical difficulties, but I definitely wanted to share with you those videos. So I had to take a little pause there.
Okay, great. I'm going to read the questions out loud and then let you answer them, Dr. Majjhoo. The first question is, what should someone do if they think they are having a stroke? Should they call an ambulance or try to drive to the emergency room?
Definitely call an ambulance, call 911. You don't want to drive those patients themselves. Again, the ambulances, what they do, we have an excellent relationship with in Genesee County with our EMS. They call us ahead of time. They have them let us know that the stroke patient is coming. So we have their medication lists ahead of time, their weight, their vitals. So we can make those quick decisions on whether they're TPA candidates, whether they are thrombectomy candidates, or whether they need surgery. So it's very important. It's best to call 911.
And I want to remind people, in case they're not familiar with Zoom, if you move your mouse around on your screen, some icons should come up at the bottom of it, and there's a Q&A little bubble icon. If you click on that, that's where you can type in your questions. Our next question is, how does TPA work?
TPA is a clot busting medication. For this audience, at this point in time, I don't want to go into the total scientific details behind it, but there's different types of clots that are formed. There's fibrin-based clots that are formed in the heart, and then there's platelet-based clots that are formed locally in the brain or in the carotid arteries and whatnot. But just basically, the TPA medicine is given through an IV, and it circulates through your blood system, and thins your blood so it can dissolve those clots.
Okay, next question. If I have a history of carotid disease, am I at risk for a stroke?
So carotid disease has an association with stroke, but if it's symptomatic, it's more so of a concern. It's very controversial at what percentage blockage that you need surgery or medical management. There are those that feel that you don't need to operate until they're more than 80% blocked. And then there are those who just think medicines are the key. I think it's just important for you to identify it and be able to discuss that with your vascular surgeons and see what is the best option for you. Now, with symptomatic carotid disease, definitely needs treatment. So if you had a stroke or a transient ischemic attack and you have carotid disease, that needs treatment immediately, as soon as possible, I should say, because we know those patients have a very high risk of a repeated stroke within the first couple of weeks, and then again within the first 6 months.
Okay, our next question is, I have a family member who had a stroke and they can't find the cause of the stroke. Is this common and what should we do?
So in those situations, I would recommend for you to see a vascular neurologist. That's what our training is. That's what we did specialized training for. So we look for those rare causes of stroke. We got to make sure that they did an appropriate amount of telemetry, which means they monitor your heart to make sure you don't have a irregular heartbeat. You may need a device inserted to monitor your heart when you're at home. You have to look at the carotids. We have to look at the blood vessels in the brain to make sure that there's no blockages anywhere. We got to look at if you're a younger patient, we look at different, look at your thickness of your blood and see if there's any reason why your blood would be thick and cause strokes. We also look at the heart to make sure there isn't a hole in the heart or a PFO that could require surgery. So definitely go see your local vascular neurologist so you can get an appropriate workup.
Okay, our next question is, what can be done for an imbalance issue post-stroke?
I think so. Once you had the stroke, again, there's damage to the brain, and then your body's got to take time to learn how to adapt to it. The brain is built, and the rest of our bodies, we're built to survive. So, with time and rehabilitation, you will improve. There's things called Epley maneuvers, or exercises where you turn your head one way or the other, and it kind of gets your body used to certain situations. When you're seeing balance issues, it's not as straightforward as, I can give you a quick answer here, but I think if you see a physiatrist that's specialized in stroke patients, I know Dr. Mookie in our program, he takes a strong interest in stroke patients. You see a PM&R doctor, he can help you get on your feet and walk again.
Okay, our next question is, can life go back to normal after someone has a stroke?
Absolutely, yes. Again, if we treat it quick enough and we can reverse a lot of the symptoms of a stroke. I gave you the example of the patient I treated Friday. She was immediately better once we removed the clot. It's not all cases are like that, and some patients require rehabilitation and time. But definitely Life King, that's the reason why we do this. And that's why time is such most importance in treating a stroke patient, because every second, millions of brain cells are dying of an ischemic brain. So every second counts.
Does having a stroke mean I will not be able to take care of myself?
Again, it depends on how long and how much damage and what part of the brain is affected. Again, every situation is different. So again, seeing the right specialists can maybe help you, point you in the right direction.
All right, next question. What is my risk of having another stroke if I've already had one?
It depends on the etiology, what caused the stroke in the first place, whether it's carotid disease or atrial fibrillation or blockage in the brain. Again, if you had a stroke or a transient ischemic attack or a mini stroke, that means you're at a higher risk than the general population of having another. And depending on the etiology, I can give you the percentages, but we would have to know what type of stroke it would be.
Okay, our next question is, how does smoking make you high risk for stroke?
Well, smoking cigarettes and everything that comes with it, leads to a chemical deterioration of the blood vessels itself, and causes a reaction that causes the atherosclerosis, or the narrowing of the blood vessels and the hardening of the blood vessel walls, to put it simply. That it accelerates that process. So you build up plaque not only in the blood vessels of your heart, but you build it up in the carotid arteries and in the blood vessels of the brain. Basically, that's how smoking makes it worse.
All right, our next question. I'm on Eliquis, so I shouldn't be at risk for stroke, right?
Eliquis is one of those DOACs that we talk about, those or NOACs, those newer oral anticoagulant agents. It has been shown to be better than Coumadin for stroke prevention in AFib patients, and with less complications, less bleeding, which it's a good thing. It's a good drug. It prevents strokes, but it will not, no medication will completely bring that risk to zero. So it would prevent about 70% of your risk for stroke, but you still need to be rate controlled and seeing a cardiologist and making sure that you're taking your beta blockers or your amiodarone or those rate controlling medications so you don't have that irregular rhythm. So I think it's important for you to continue to follow with your cardiologist to make sure that your heart is beating normally and you are taking your blood thinner. Especially if you are on Eliquis, make sure that if you ever need to stop it for a surgery or a procedure, make sure you let your doctors know, or maybe get bridged with Lovenox, the shots for those procedures, so that you don't increase your risk of stroke during those procedures.
Okay, our next question. Are there support groups available for people like me who've had a stroke?
Absolutely. I think if you look at our McLaren website and our Neuroscience Institute, Sherry, I'm sure we can provide that for them. We have support groups locally. Ashley, our neuroscience coordinator, has helped to develop these, and we really appreciate that, and we can get more information for you.
Okay. Does anyone else? I don't see any new questions. This is your chance to talk to our expert. If anyone, I'll give you a couple minutes here to type, but I think Dr. Majjhoo, I don't mean to put you on the spot, but what are your top 3 takeaways simple takeaways that you hope everybody participating, takes away from your talk today?
So number 1, stroke is preventable. It's 80% of them can be prevented if you just, again, go back to that slide. High blood pressure, high cholesterol, if you have AFib, carotid disease, diabetes, quit smoking. If you have a family history of TIA or stroke, you know these things. Make sure you're on the right medications. Make sure you're doing everything you can to prevent another stroke from happening. I think that is the key thing I want to get across. Also, I want to go to a slide where we have our B.E.F.A.S.T. Give me a second here. B.E.F.A.S.T. If you have the sudden onset of these symptoms, time is of essence. Call 911, get to the ER so we can take care of you as quickly as possible. Every minute, millions of brain cells are dying. And so it's very important that you are assessed by a specialist as soon as possible for the best possible outcome. You said 3.
I did.
The third one is there are treatment options out there. So, if you have an interventional neurologist see you, we not only can give you TPAs and control your medically, we can also do surgical procedures on you to help you with your stroke. So please get to the emergency room. Again, time is of essence.
Okay, well, we want to thank you, Dr. Majjhoo, for taking time out of your very busy schedule to speak with us. I also want to thank Ashley Atcoy, the stroke program coordinator, who Dr. Maju has mentioned a couple of times here at McLaren Flint, Jasmine Brown from the marketing department. They also helped make this presentation possible. And of course, thank you to everyone who joined us for this important discussion about stroke education and awareness. If you have any additional stroke-related questions, please send them to flintmarketing@mclaren.org. That's flintmarketing@mclaren.org. And we will be sure and get those to Dr. Majjhoo and Ashley and get your questions answered. Thank you again.
Thank you. Good night, everyone.